you, Jeff. We're a quality improvement organization. For those who don't know us, Health Services Advisory Group has a contract with CMS to improve quality of care for the Medicare fee-for-service beneficiaries in the state. But we know that it's not just for Medicare. When we change the system, we change the care for the better for all population. So I'll just go over a few things about this special project, which is in addition to our current scope of work, which is a huge scope of work. CMS set aside a pot of money for special projects, the special innovation project. And so, as you know, CMS has three aims, which is better care, healthier people, and smarter spending, which is what Arnie talked about earlier. And so this special project, they have parameters, and they ask all the QIOs across the country to submit proposal for funding for a special project based on this criteria that the quality improvement intervention is scalable, that there is evidence, some moderate level of evidence that this will work. And so you heard what Kaiser had just done, that it's possible, it's feasible, it can be done. And that the interventions are focusing on streamlining patient flow and resulting in efficiencies and improved care and lowering costs. So thinking about what I heard and participating at the RightCare initiative through Arnie's presentation and his team presentation on the stroke bundle of care, which is engaging patients to get them to recognize their stroke symptoms early so that they can access treatment early. And also optimizing the pre-hospital phase of EMS communication with the hospital, and then implementing improvement inside the hospital. So, we also heard from Kaiser last year and in February about the success that they have done. And so a couple of months after that, CMS issued this call for proposal. So we decided to put together a proposal based on these two great concepts and ideas. And so the proposal was submitted in May, and by September, CMS awarded the proposal as one of the funded special studies. And this project started in October of this year. So the project partners are, of course, Kaiser and Stanford, and California Stroke Registry, California Coverdell Program, Dr. Janet Bates from CDPH, and the Contra Costa EMS EMS agency, and American Heart Association, and American Stroke Association, and of course, RightCare Initiative. One other criteria that I failed to mention is that CMS is looking for, there is some evidence of local commitment and collaboration that is going on. And Contra Costa has 8 hospitals, and 6 of them are primary stroke centers, and they have been meeting with the EMS agency on a quarterly basis already, on an ongoing basis, collaborating and improving the system of stroke care in Contra Costa. And that's why we picked Contra Costa as the pilot, as a project. And so the project aims are to improve the door-to-needle time and increase the percentage of the acute ischemic stroke patients who can benefit from early TPA and endovascular treatment, and reduce disability and mortality, thereby improving care and lowering costs. So what we will be doing in this project is to apply lean methodology, as Dr. Klingman has so eloquently described, in terms of this, leaning out the processes so that we can get to rapid identification of stroke cases and rapid delivery of the IV TPA, and selection of the patients with large vessel occlusion so that they can be rapidly transferred to centers that can do endovascular treatment. And of course, data sharing and quarterly feedback. This eventually, CMS would like to have this spread, and we will promote peer-to-peer learning and develop a toolkit or a change package that consists of these improved processes and tips on how to get to lower the needle time down to a world class of 30 minutes or below, and then share the project results through the Right Care initiative in forums such as this one, and also through other area channels for dissemination. And so the project will have a steering committee, which will be chaired by Dr. Klingman, and the steering committee will be working on developing consensus on the protocols within the Contra Costa County and improving the system of stroke care there. And then there will be 3 work groups. One is the Consumer Community Engagement Work Group, which will be led by the American Heart Association and American Stroke Association. The first meeting is already scheduled for that group, December 6th. The charge to that group is to conduct an intensive patient and family caregivers education regarding early recognition of stroke symptoms. And the second work group is the hospital and EMS work group, which is already occurring, being convened by the Contra Costa EMS agency, and we will just continue to support them and help address some of these issues. And the last one is a new work group, which is a hospital stroke coordinators work group, where they will be sharing the best practices in order to share and improve the door-to-needle time and endovascular treatment time. So this is just an example of a community initiative that's sponsored by Genentech. It's called Strike Out Stroke. And AHA, of course, has the FAST campaign. So we'll be looking at all of these initiatives to see what will be the best one for the Contra Costa community and conducting a campaign. Thank you.
5 minutes for some questions, so please. Hector.
So one of the things that in your description of the current state in most places was that there was a lot of individuals contributing to the care process at different points in time. And I wondered, what did it take to get everybody there at the same time for the station? Do you have to increase staffing at all, or just reorganize norms of drop what you're doing and go attend to this?
Yeah, no, it's a good question. Everybody would like me to increase staff. There's no money for increased staffing. We know that. It's not going to happen. So what we ended up doing was we said, look, we're taking care of stroke patients anyway. And this way we're engaging a lot of people all at once, but for a very brief period of time, because that argument came up. And I said, okay, well, you've got one nurse taking care of this patient for an hour, plus there's another nurse helping out. How about if we engage you for about 10 or 15 minutes intensely, and then you go back and do your work? So it really, yes, it's like a code, but again, the codes don't let it get done. And so it was a rethinking, and there was a little bit of pushback from some people, but once they sort of saw it in process, they realized that, you know, yes, you're intensely engaged in this sort of, it looks very much like a code of fashion, but it's a lot. The overall amount of time is not different because of all the, you know, the steps are the same. It's just a matter of how you jump on it. It did take a lot of discussion among the EDs. This was not done in isolation. The ED group looked at their work. It's a huge amount of work change for radiology. It's a huge amount of work change for CT techs, but getting everybody on board. And then we did multiple simulations to run through the thing. So that, I didn't mention that, but I can't emphasize enough how much working through doing a bunch of simulations made a big difference.
Arnie?
Jeff, what are your thoughts as to what it was about Melbourne that allowed them to drop the door-to-needle time, you know, so much more quickly than we've been able to set up to take best practice and move it quickly?
So it's, I think what they did, we'd have to ask them about it, that specific question the next time I see Maritoja. I'll ask him, but I think that what happened is the hospital got committed to it. There was a model to use, and they were intensive in saying, definite in saying, we're gonna blow up the way we've done things before. I don't think it's incremental, I think you have to completely change it. And I think what they did is they made that kind of commitment. Now, they do have some advantages. The Melbourne hospitals were about 500 beds, and Maritoja said, gee, it'd be better if they were bigger, which is interesting for me, because I think our biggest hospital is maybe 300 beds, but it does make it easier if you've got that team on board. I think the innovation here was the video adding to the process, but I believe you have to make that decision, throw out your old way of doing things, use a model that works, and go back and question assumptions, and I think that's what they were able to do. Now, you've got to get a hospital willing to do that.
Since I'm a developing country guy, I confess I'm worried about the door needle as the benchmark. Why aren't we talking about stroke to needle?
Well, yeah, no, I mean, stroke to needle, the reason we don't talk about stroke to needle is we sort of have no control over it, but you're right, because really stroke to needle is where I'm very interested in community education. People need to call 911 because they wait or they come in, so that's one. The other thing is, the next step, minimize scene time, right? Because if the paramedics are screwing around for too long, they got to get enough information. And then the other thing I really want to do, we're actually going to be piloting getting the video into the ambulance grid. So that and actually it's in San Rafael, which is not one of my busier counties, but the ED doc is also the EMS director. It makes it easier to do. But we'll be doing video in the rig, because why not examine them? Because if you could actually examine them in the rig by video, you could potentially get your door to needle time down to 5 minutes. If we could get a weight, and there's a lot of ifs involved, but you could go straight to CT, CT looks okay, and you could do something really great that way. You can't get by without a CT, so if you're in developing countries, you've got that issue. But that idea that, just get them in and get them treated is kind of a shift from what we've been doing before.
You mean that if you had a stroke in Tanzania, you'd rather not have TPA, you couldn't have a CT? I doubt that.
Oh, yeah, no, absolutely. There's no way I'd want to have TPA without a CT scan. I mean, you got to
What
come up with
proportion
something
are
else,
now, right?
15%.
And you wouldn't take that bet?
No, I don't know.
All right, let's go on to the next one. We're a little over.